So hello everyone. Today we would start the topic of abdomen, topography of abdomen. The abdomen is located anterior laterally, and it is a muscular aponeurotic formation. Okay, and it is limited by abdominal wall from the anterior and lateral side. What are the borders? Superiorly, there is costal arch on both sides. And xiphoid process. Inferiorly, there is iliac crest, anterior superior iliac spine, inguinal ligament or inguinal folds, pubic symphysis and pubic tubercle. Laterally, it is a continuation of mid-axillary line, which is also called as Lesgraf's line of both sides. So there are three borders: superior, inferior, lateral. Superior, costal arch on both sides and xiphoid process. Inferiorly, iliac crest, anterior superior iliac spine, inguinal ligament, inguinal fold, pubic symphysis and pubic tubercle. And laterally, continuation of mid-axillary line, Lesgraf's line of both sides. Now, what are the orientation on this abdominal wall? Now, there are two orientation. One is horizontal and another is vertical. Now, horizontal is superior horizontal, inferior horizontal, and vertical is right mid-clavicular, left mid-clavicular. While reading, just imagine whatever you are reading, be in that presence and imagine. It is very easy. You don't need to mug up, you don't need to get confused. You just need to be in the flow and imagine. Horizontal line, vertical line. Okay. There is superior horizontal, inferior horizontal line. Fine. Now this superior horizontal line, it joins the lowest point of costal arc, and area superior to this is called epigastrium. Okay. Inferior to horizontal line, it joins the anterior superior iliac spine on both the sides, and area inferior to the line is called as hypogastrium. Now vertical line, how does it divide? From the right mid-clavicular line, joins the right clavicle middle point to the right inguinal ligament, and left mid-clavicular is joined left clavicular middle point to the left inguinal ligament. Fine. See, this is epigastric region, this is hypogastric region. Fine. These are horizontal lines: epigastric, hypogastric, umbilical region. Fine. Now there are quadrants. Now how these quadrants are formed? This is sternal line and transverse line. The quadrants of abdomen are divided into four quadrants: right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Fine. Now there are also regions. These regions are divided into 9 regions. Abdominal wall is divided into 9 regions. How? Right hypochondric region, epigastric region, left hypochondric region. Up to the gastric, epigastric. Down to the gastric, hypogastric, and umbilical region is in the center. Right hypochondric, left hypochondric. Here is costal arc, below that this region, so right and left hypochondric. Here there is a lumbar region, so right and left lumbar region, which is also called as right lateral abdominal region, left lateral abdominal region. And besides the hypogastric region, there is right iliac or right inguinal, left iliac or left inguinal region. Fine. Now, what are the projections of the organs on the abdominal wall? In the right hypochondric region, what are the organs located? Right lobe of the liver, right suprarenal gland, right colic flexure of the large intestine, and gallbladder is also present. See, here it is written. Okay. What is located in the right hypochondric region? Right lobe of the liver, gallbladder, right suprarenal gland, right colic flexure of the large intestine, and also superior pole of the kidney, right kidney. Fine. What is located in the epigastric region? In epigastric region, which is also called as proper epigastric region, left lobe of the liver, okay, stomach, pancreas, body of the pancreas, superior part of the duodenum, inferior vena cava, abdominal aorta, colic trunk, colic plexus, and lesser omentum. And also the adrenal gland is also present. In the left hypochondric region, the organs are part of the stomach, left colic flexure of large intestine, spleen, next is left suprarenal gland, tail of the pancreas, and superior pole of the left kidney. In the right lumbar region, ascending colon, right kidney, except the superior pole, which is located in the right hypochondric region, right ureter and loop of small intestine. Okay. What are those? Ascending colon, right kidney, right ureter, loop of small intestine. In umbilical region, what are the organs present? Duodenum, except the superior part, head of pancreas, transverse colon, loop of small intestine, and inferior vena cava. In the left lumbar, descending colon, left kidney, except the superior pole, which is in the left hypochondric, left ureter, loop of small intestine. Okay. In the right iliac, there is right ureter, right external right external iliac artery and vein. Okay. In the hypogastric region, there is supraampullary part of the rectum, abdominal part of the ureter. Fine. Also distal part of the sigmoid colon, supraampullary part of the rectum, and urinary bladder, but ureter, it is after the first trimester. Left iliac, there is sigmoid colon, left ureter, left external iliac artery and vein. Now these are the projection of organs on the abdomen. The layers. In the skin, it is thick with hair follicles. Fine, especially in the hypogastric region, especially in males. Subcutaneous tissue, it is a thick layer of fatty tissue. Primary site of adipose depot for the body, especially in the males. Now, there is thoracoepigastric vein and greater saphenous vein. Now, this thoracoepigastric vein is a branch of paraumbilical vein. Now, these two, thoracoepigastric vein and greater saphenous vein, are cavo-caval anastomosis. Paraumbilical vein, superior and inferior epigastric vein, is an anastomosis of portal caval anastomosis. It helps. Now, the superficial fascia. It continues of superficial fascia of thorax. It is a continuation. It is divided into superficial lamina and deep lamina. Superficial lamina is called as Camper's fascia and deep lamina is called as Thompson's fascia or Scarp's fascia. Now this superficial fascia is a fatty layer continuation with thigh as fascia lata, and it is not attached to the inguinal ligament. Superficial lamina of the superficial fascia, it is not attached to the inguinal ligament. Deep lamina is membranous layer, continues to form superficial fascia of the penis and scrotum in male and perineal fascia in female. And this deep lamina is attached to the inguinal ligament. Okay. Now we move on to the muscle. Which are the muscle? Pyramidalis muscle. Okay. Rectus abdominis muscle. External oblique, internal oblique, and transverse abdominis muscle. Now next is the deep fascia. Above the arcuate line, Now this deep fascia, it is divided. There is an arcuate line. If we see above the arcuate line and below the arcuate line, here it is above the arcuate line and here it is below the arcuate line. If we take a cross section, then what do we see? Aponeurosis of the external oblique muscle and half of the aponeurosis of internal oblique muscle from the anterior layer of the rectus sheath. The other half of the aponeurosis of internal oblique muscle plus aponeurosis of transverse abdominis muscle is a posterior layer of rectus sheath. Okay, but below the arcuate line, aponeurosis plus external oblique muscle plus internal oblique muscle plus transverse abdominis muscle is the anterior layer of rectus sheath. Means this internal oblique muscle, it is divided. Aponeurosis of this internal oblique muscle, it is divided. Half is in the anterior layer with aponeurosis of external oblique muscle and other half is with aponeurosis of the transverse abdominis in the posterior layer. Okay. Now next is transversalis fascia. This transversalis fascia is a continuation of endothoracic fascia which continues into the pelvic cavity as endopelvic fascia. It is attached to the iliac crest and half of the inguinal ligament and continues as iliac fascia. Attached to the pubic tubercle, pubic crest and Cooper's pectineal line medially. Anterior wall, it forms femoral sheath. Fine. Now preperitoneal fatty spaces. It is a thin above the arcuate line. Okay. And superior epigastric vessels and deep circumflex iliac vessels are present. Then the last layer is peritoneum. Okay. Now what are the weak places? Places where tendons are not closely fused together and foramina or fissures are formed and hernia tends to appear. Wherever the tendons are not closely fused together and foramina or fissures are formed, then in this foramina or fissure, the organs might tend to penetrate and hernia tends to appear, which is called hernia. Now what are the types? Common hernia are white line, which is linea alba or Hunter's line. Hunter's line. Next is umbilical region, regio umbilicalis. Inguinal region, semilunar line. It is seen as a shallow groove when rectus abdominis is tensed, lateral on the lateral border. Okay. Next is arcuate line. Arcuate line, it is a curved tendinous band in the sheath of rectus abdominis muscle 4 to 5 cm below the navel. It is derived from aponeurosis of transverse abdominis muscle or internal oblique muscle. It is inserted into the white line. We will study this hernia in further detail. What are the blood vessels? Blood vessels are superior epigastric artery from internal thoracic artery, inferior epigastric artery and deep circumflex iliac artery from the external iliac artery, superior circumflex iliac and superior epigastric artery, anterior and collateral branches of posterior intercostal vessels of 10th and 11th intercostal spaces and forms anterior branch of subcostal artery and same as veins. Okay. Next are innervations. Innervations are thoraco-abdominal, also known as inferior intercostal nerve. Anterior abdominal branches of anterior primary rami of the inferior 6th thoracic nerve, which is T7 to T11. Okay. Next is subcostal nerve from T12. Iliohypogastric and ilioinguinal nerve from T1. T7 to T9 is to skin superior to umbilical. Okay. T10. Okay. T10 innervates the skin around the umbilicus. T10 skin around umbilicus. Fine. The T7 to T9 skin superior to umbilicus, as I said. Cutaneous branch of subcostal nerve T12, iliohypogastric or ilioinguinal L1 supplies to the skin inferior to the umbilicus. Now next is topography of umbilical region and white line. There is an umbilical ring in the umbilical region. It is weak because it consists only 3 layers: skin, endo-abdominal fascia and peritoneum. Keep in remember, muscle is absent. White line formed due to fusion of aponeurosis of broad muscles of abdominal wall where muscle is absent. It is wide in the upper part and narrow in the lower part. Keep in remember, wherever the hernia is forming in the white line and the umbilical region, muscles are absent. Topography of the inguinal region. There is an inguinal triangle which is also called as Hasselbalch's triangle. Now what are the borders? Superiorly, it is a horizontal line between the lateral and medial 1/3 of the inguinal ligament. See, this is the inguinal ligament. Okay, it is horizontal line between the lateral and middle 1/3 of the inguinal ligament. Medially, lateral margin of rectus abdominis muscle. Okay. Inguinal canal. Inguinal canal walls are anteriorly, it is aponeurosis of external oblique muscle. Posteriorly, transversalis fascia. Roof is inferior border of internal oblique and transverse abdominis muscle. And floor is inguinal ligament. Once again, floor is inguinal ligament. Okay. Anteriorly is aponeurosis of external oblique muscle. Posteriorly is transverse fascia. Okay. And roof is internal oblique and transverse abdominis muscle. Content through this is spermatic cord and ilioinguinal nerve. In female, it is round ligament of uterus, ilioinguinal nerve and genital branch of genitofemoral nerve. Now, there is rings. Hernial contents may be loops of the small intestine, sigmoid colon or other organs as liver or spleen. Now, what are the classification? First is external and internal hernia. External is outside the abdominal or pelvic cavity in the called as umbilical hernia. Internal hernia is inside abdominal or thoracic cavity, which is diaphragmatic hernia. What are the anatomical classification? Inguinal, umbilical, white line, etc. Etiological classification would be congenital and acquired. Acquired would be post-operative traumatic neuropathic. Clinical classification: reducible or free hernia, irreducible hernia, strangulated hernia. Reducible or free hernia is the content moves freely from the abdominal cavity to the hernial sac. Okay. Irreducible hernia, the content cannot move freely owing to the formation of adhesive process in the abdominal cavity. The strangulated hernia is irreducible hernia in which compression of the vessels of hernial content occurs, leading off the hernial sac and its content. Now, according to the size of hernia, there are small, medium, large and giant. According to the presence of complication, uncomplicated, complicated. Now, what are the types of strangulated hernia? First is Litter's hernia. Hernia of Meckel's diverticulum. See here. First one, parietal Richard's strangulated hernia. Okay. Retrograde Madel's strangulated hernia. And periperitoneal sliding hernia of appendix. Next is elastic strangulation due to external pressure. Fecal strangulation due to internal pressure exerted by fecal mass. It is a portion of bowel strangulation, and some loops of bowel are strangulated here. The next is types of inguinal hernias. First is direct, indirect or oblique, and third is sliding. Direct is herniated organ passes through medial inguinal fossa and never enters scrotum, located separately from spermatic cord. Indirect or oblique is hernia passes through the lateral inguinal fossa and inguinal canal and then enters the scrotum. Located with the spermatic cord, there are two differentiation, congenital or acquired. Next is sliding. Visceral peritoneum forms a portion of hernial sac. Mesoperitoneal organs like cecum and urinary bladder are involved. Now, in this congenital inguinal hernia, acquired inguinal hernia, it is congenital and acquired inguinal hernia are shown in this. Fine. Next is operative axis of the abdominal wall. Now, what are the operative axis? First is through laparotomy. Do an incision through any part of an abdominal wall. All the surgical approach to the organ of the abdominal cavity is divided into longitudinal, transverse, oblique, angular combined. Now, types of longitudinal, transverse and oblique laparotomies. See, longitudinal approach. There is midline approach, paramedian, transrectal and pararectal. These four approaches are there of longitudinal approach. Now, according to midline, there are again subdivisions. Longitudinal approach, first is midline, superior midline, middle midline, inferior midline, total midline. Now, what does it mean? Midline, superior midline, along the white line of the abdominal wall from the xiphoid process to umbilicus. Universal access to the organs of upper floor of the peritoneal cavity. Okay. Now, next is middle midline. Along the white line of the abdomen from the middle of the distance between the xiphoid process and umbilicus to middle distance between the umbilicus and pubic symphysis. Approach to the organs of the upper and lower floor of the abdominal cavity, and it helps in inspection of the peritoneal cavity. Next is inferior midline. From umbilicus to the pubic symphysis, used for surgery of lower floors of the peritoneal and pelvic cavity. Next is total midline, used to extensive process in the peritoneal cavity. Now, what are the advantages of this midline approach? Advantages: less trauma, easier access to the pathological focus. Disadvantages is delay post-operative scar. Next is paramedian. Paramedian, along the medial edge of the rectus abdominis muscle, 2 cm lateral to the white line of the abdomen. Skin, subcutaneous fatty tissue, superficial fascia, which is superficial and deep fascia. Anterior layer of the rectus sheath are cut and drawn aside by blunt hook. Posterior layer of rectus sheath, transverse fascia, preperitoneal fatty tissue and parietal peritoneum are cut. What are the advantages? Easy access, formation of post-operative scar, and disadvantages is high traumatic rate and insufficient time for hemostasis. Next is transrectal. Rectus abdominis muscular fibers are separated by blunt way with the help of scissor or hemostatic forceps. What is advantage? Access to the pathological focus and formation of valued post-operative scar. Disadvantage is high traumatic rate and insufficient time for hemostasis. Last of the longitudinal approach is pararectal approach. Along the lateral edge of the rectus abdominis muscle, like paramedian laparotomy, rectus abdominis muscle is drawn medial by blunt hook. For example, in acute appendicitis, we call this as Lenard's axis. performed when diagnosis is not confirmed before the operation. Now, advantages and disadvantages are same as above. Next approach is transverse approach. There are two, superior and inferior approach. Superior transverse laparotomy is done at the superior horizontal line. All tissues of the anterior abdominal wall are cut transversely. Inferior approach is performed below the inferior horizontal line. Skin, subcutaneous tissue, superficial and deep layer of the superficial fascia and aponeurosis of the rectus abdominis muscle are cut transversely. All deep layer are cut longitudinally. In superior approach, all the tissue of abdominal wall are cut transversely, but in inferior approach, all the superficial layer until the aponeurosis of rectus abdominis muscles are cut transversely, and all the deep layers are cut longitudinally. Next is oblique approach. Upper oblique, lower oblique. Upper oblique is parallel to the costal arc and all tissues are cut in same direction. Lower oblique is parallel to the inguinal ligament, which is used in acute appendicitis and called as Volkovich-Diakonov's axis. Skin, subcutaneous fatty tissue, superficial and deep layers of the superficial fascia are cut parallel to the inguinal ligament. Aponeurosis of external oblique, internal oblique and transverse abdominis muscle is cut. Next is laparoscopy. Visualization of abdominal cavity with a laparoscope with an incision, which is called as laparocentesis. What is indication? Indication, it is done diagnostic laparoscopy, laparoscopic appendectomy, cholecystectomy. Okay. What are the contraindication of this method? Patient is intolerant to general anesthesia, patient with irreducible hernia, patient with acute ileus, pregnant patient, patient with hiatal hernia or obese patient. So next would be laparostomy. Laparostomy, it is creation of an opening or communication between the abdominal cavity and external environment. Laparocentesis is puncture or incision on the anterior lateral abdominal wall. It is done for aspiration of fluid, which is also called as exudation, or for future laparoscopy. Now we move on to the stages of the operation for abdominal hernia. What are the first principle? Herniatomy, incision of the hernia, removal of hernia canal or place. Hernioplasty, surgical repair of the hernia. Herniatomy is removal. Plasty is surgical repair. Depending on the material used for plastic repair, they are divided into autoplastic, alloplastic or combined. Autoplastic is taken from the tissue of the organism. Alloplasty is a foreign tissue which is xenogenic or explant or combined methods. Okay, xenogenic means tissue of the other organisms, or explant is non-biological tissue. Technique for hernioplasty may be done by musculoaponeurotic, musculofacial, aponeurotic hernioplasty. Stages is surgical approach to the hernia by incision of the tissue of the abdomen, excision of the hernial ring, extraction of the hernial sac, opening of the hernial sac and inspection of the contents, closure of the inguinal opening up to the normal size, plastic repair of the hernial ring. Fine. See. Next is surgical treatment of inguinal hernia. It is performed under local anesthesia. Fine. General anesthesia is given only for the children of 1 year old, or patient not tolerate to Novocaine and patient insisting on general anesthesia. What are the methods? Now, for the inguinal hernia, methods are Bason's method. First is Bason's method. What he did, built up a posterior wall of the inguinal canal. After extraction of hernial sac, spermatic cord is clamped and held. Borders of transverse abdominis muscle, internal oblique muscle, transversalis fascia and inguinal ligament are interrupted Sutures. Other sutures between the borders of rectus sheath and pubic bone periosteum. Okay. Inguinal space is closed and posterior wall is strengthened. Spermatic cord on the newly formed posterior wall of the inguinal canal. Over the spermatic cord, the aponeurosis is restored and interrupted sutures are made. See, the Basin's method. Suturing of the internal oblique, transverse abdominis and rectus abdominis muscle to the inguinal ligament posterior to the funiculus spermaticus. Fine. Next is Martianov's method. After opening the inguinal canal, dissect the aponeurosis of external oblique muscle. Removal of the hernial sac is done. Then superior flap of aponeurosis of external oblique muscle is sutured to the inguinal hernia by interrupted sutures. An inferior flap is sutured up to surface of aponeurosis. It will be duplication of the aponeurosis of external oblique muscle. Fine. Next is Girard's method. Stitch the superior flap of aponeurosis of external oblique muscle to inferior margin of the internal oblique muscle and transverse abdominis muscle. First stage is access to the muscle and inguinal ligament. Then second is access to the aponeurosis. And third we need to do same as the Martianov's method, which is called duplication. Next is Spasokudski method. We need to stitch the aponeurosis and muscles together. After penetrating the aponeurosis and muscles with a needle, reach the inguinal ligament. Fine. Suturing the internal flap of the aponeurosis to the external oblique, internal oblique and transverse abdominis muscle to the inguinal ligament. This is called as Spasokudski method. Next is Kimbarovsky method. Margin of internal oblique and transverse muscle is covered by superior flap of aponeurosis of external oblique muscle. Needle is passed through the aponeurosis muscle and returns to the aponeurosis and then reaches the inguinal ligament. Next is Postemsky method. Done to close the inguinal ligament by removing the spermatic cord laterally. Plastic narrowing of the inguinal ring, which is 0.8 cm. It is an important stage. Transverse incision of internal oblique muscle and transverse abdominis muscle. Spermatic cord displaced laterally. Superficial and deep inguinal rings are in one plane. Aponeurosis of internal oblique muscle and transverse abdominis muscle is fixed to pectineal ligament. Okay, next is Schold eyes method. Lateral border of transversalis fascia is stitched to the lower surface of rectus sheath. Uninterrupted sutures are tied at the pubic tubercle and on other end left long. Suture is continued, connecting both parts of the transversalis fascia up to the deep inguinal ring. Then the suture is turned to medial border of the transversalis fascia to inguinal ligament. Next is Kukudzanov's method. It is done to restore the posterior wall of the inguinal canal. Suture is placed between the pectineal ligament, rectus sheath and aponeurosis of transverse abdominis muscle. Next is Lichtenstein's method. Direct hernia, oblique hernia. In direct hernia, transversalis fascia is dissected above the hernial sac and reduced. Then this fascia is sutured with uninterrupted sutures. Oblique hernia, after excision of the hernial sac, deep inguinal ring is restored. Then transversalis fascia is sutured. Here, polypropylene mesh is used for plastic repair of hernial ring. Implanted in the spermatic cord and fixed by interrupted sutures to the inguinal ligament. Now, the superior edge of polypropylene mesh is stitched by interrupted sutures to internal oblique muscle. Then the deep inguinal ring is formed. Inferior edge is fixed with 2 to 3 stitches to the pubic tubercle together with the superior pubic ligament to prevent the formation of the femoral hernia. Now, next surgical treatment for the femoral hernia. Approach is from femoral, inguinal or intra-abdominal. There are two methods. Ruggie Parlovico's method or Basin's method. In the first method, the incision is in the hernial sac through the inguinal canal. After excision of the hernial sac, the hernial ring is restored by the suturing of inguinal and pectineal ligament. In the Basin's method, we need to do vertical incision in the thigh. After excision of the hernial sac, hernial ring is restored by suturing of inguinal and pectineal ligament. Next is surgical treatment for umbilical hernia. Here are three methods: Spasco's method, Mayo's method, Lexer's method. Sapesco's method used to cut the umbilical ring. Longitudinal direction and duplication of the aponeurosis is made longitudinally. Mayo's method, cut the umbilical ring in the transverse direction and duplication of the aponeurosis is made longitudinally. Lexer's method, a purse string is applied around the umbilicus. Surgical treatment of the hernia of the white line. We need to do herniatomy by traditional method. Then edge of the aponeurosis is sutured transversely, or Sapesco's Diakonov's method is used. According to him, duplication is done in the vertical direction. Aponeurosis of white line is stitched to anterior layer of the rectus sheath. Surgical treatment of the strangulated hernia. Now, stages: surgical approach to the hernia by incision of the tissue of the abdomen, excision of the hernial ring, extraction of the hernial sac, opening of the hernial sac and examination of the viability of the organs, closure of the inguinal opening up to the normal size, plastic repair of the hernial ring is done. Now, criteria for estimation of viability of the small intestine is restoration of the bowel to normal pink color, absence of marks of constriction and dark spots, presence of pulsation, presence of intestinal peristalsis. Surgical treatment of sliding hernia is performed like previous operation. Surgeon must carefully examine all sides of the hernial sac before its opening, because the wall of the slide organ may cut accidentally. Next is herniatomy in children. General anesthesia is given. Suture is made through the aponeurosis of external oblique muscle without its dissection. Opening of the inguinal canal is also forbidden. Now we move on to the abdominal cavity. It is a space in the trunk below the diaphragm which is divided into abdominal cavity proper and pelvic cavity. Now, borders of this abdominal cavity. Anterolaterally, there are muscles which are those rectus abdominis, external oblique, transverse abdominis and internal oblique muscles. Posteriorly, lumbar segment of the spine, psoas major and quadratus lumborum muscle. Superiorly, there is diaphragm. Inferiorly, iliac bone and pelvic diaphragm. Division of the abdominal cavity is divided into three stories: upper, middle, lower. Upper one borders are superior, inferior. Superiorly, there is inferior surface of diaphragm. Inferiorly, there is transverse colon. Contents are hepatic bursa, pregastric bursa, omental bursa, liver, stomach, gallbladder, spleen, superior pole of the kidney, adrenal gland, superior part of the duodenum, abdominal aorta and inferior vena cava. Middle, it is from transverse mesocolon to inferiorly inlet of the lesser pelvis. Right and left paracolic canal, right and left mesenteric sinus, mesentery, sigmoid mesocolon, duodenojejunal recess, superior and inferior ileocecal recess, large and small intestine. Lower, it is superiorly inlet of the lesser pelvic and inferiorly pelvic cavity. Contents are retrovesical pouch in the male, retrouterine and utrovesical pouches in the female and pelvic organs. Now next we move on to the peritoneum. Peritoneum is a serous membrane lining the abdominal and pelvic cavity. In male, the peritoneum is closed. In female, the peritoneum communicates with the external environment by the means of uterine tube. Now, it consists of two layers: parietal, visceral. Between these, there is peritoneal cavity which contains peritoneal fluid. Now, the extraperitoneal tissue. It contains large amount of fatty tissue is lodged between the peritoneum and abdominal wall. Abdominal wall and peritoneum, there is extraperitoneal tissue which is large amount of fatty tissue. It is richly developed on the posterior abdominal wall and poorly developed on the anterior abdominal wall. Now, see, anterior side, posterior side. This is parietal layer, okay, and this is peritoneal fold, and this is visceral layer. This is visceral covering the organ, bounded by the organ, bounds the organ. This is peritoneal fold, and this is parietal layer. Okay. Now, parietal layer is composed of fibrous layer. It lines the inner surface of abdomen and pelvic cavity and forms outer limit of the peritoneal cavity. Visceral layer is composed of mesothelial cells, covers the outer surface of the abdominal visceral organs. It receives same artery and nerve supply as the wall it lines. The parietal layer is more sensitive to pain because innervates by somatic innervations. Visceral layer is innervated by autonomic innervations. Parietal peritoneum of the pelvic is devoid of somatic innervation, and here in visceral layer, pain is only felt when the organ is distended or ischemic. Now, what is function? Reduce friction from the movement, peristalsis and respiration. Protection, it contains various phagocytic cells and lymphocytes which participates in the immune reaction. There is greater momentum, can move towards the site of infection to prevent perforation. Absorption, mesothelium cells act as a semi-permeable membrane that permits water and electrolytes to diffuse straight into the blood vessels. Healing and adhesions, fibroblast promotes fast healing of wound. Storage of fat, fat is richly developed in the peritoneal fold. Relation to the visceral organs of the peritoneum. Now, the visceral organ, it is not always completely covered to the organ. Sometimes it is intraperitoneal, sometimes it is mesoperitoneal, sometimes it is extraperitoneal or retroperitoneal. Now, intraperitoneal is covered by all four sides, generally mobile and can be moved away to access the deeper organs in surgery and prone to herniation. It includes stomach, bulbous duodenum of the superior part of the duodenum, jejunum, ileum, appendix, transverse colon, sigmoid colon, supraampullary part of the rectum, spleen and ovaries. These are intraperitoneal organs. Mesoperitoneum is covered by three layers. Degree of mobility is between intra and extra. Organs are liver, gallbladder, ascending part of the duodenum, cecum, ascending colon, descending colon, ampullary part of the rectum, urinary bladder when distended and uterus. Extraperitoneal organs or retroperitoneal organs is covered by one side, located in the retroperitoneal space and not movable at all. Now, organs in the extraperitoneal or retroperitoneal organs are descending and horizontal part of the duodenum, anal canal, pancreas, kidney, adrenal gland, ureters, urinary bladder when empty, major vessels like the abdominal aorta and inferior vena cava. Peritoneal formation, mesentery or mesenterium. It is a broad fan-shaped peritoneal fold that suspends jejunum and iliac loop from the posterior abdominal wall. Now, the borders of this mesentery, roof of mesentery is attached border and it extends from duodenojejunal junction to ileocecal joint or extends from left of L2 vertebra to right sacroiliac joint. Intestinal border or free border which suspends jejunum and ileum. Now, contents of this mesentery are superior mesenteric artery, superior mesenteric vein, jejunum and ileum. Next is mesocolon, which is mesentery of the large intestine. It contains neurovascular bundles and connects to the posterior abdominal wall by mesocolon. Okay, types of mesocolon are mesocolon transversum connects the transverse colon to the posterior abdominal wall. Mesocolon sigmoidum connects the sigmoid colon to posterior abdominal wall. Mesoappendix connects the appendix to the posterior abdominal wall. Transverse mesocolon, mesosigmoidum and mesoappendix. Next is omentum. Duplicature of mesentery, which consists large amount of fatty tissue. Lesser connects the stomach and liver from the portal triad and proximal part of the duodenum. It is formed by hypogastric and hepatoduodenal ligament, and greater it connects stomach and transverse colon. It is formed by gastrocolic ligament. There are 4 peritoneal folds and fuse to form 2 lamina, anterior lamina and posterior lamina. Anterior lamina, greater curvature of stomach to anterior to transverse colon to pubic bone and ascends and form posterior lamina. Once again, 4 peritoneal folds and fuses to form 2 lamina. Okay. Now this anterior lamina and posterior lamina. This anterior lamina, it starts from greater curvature of stomach to anterior to the transverse colon, from this to pubic bone, and from pubic bone it ascends to form posterior lamina. Fine. Now this posterior lamina, from the transverse colon it ascends to anterior border of the pancreas and divides into 2 layers. First layer, it covers anterior part of the pancreas and goes up to diaphragm, and second, inferior part of transverse mesocolon and continues with transverse mesocolon. Now next is ligaments. Okay. Ligament, it helps to connect the adjacent organs. Okay. For example, hepatogastric ligament. There are many ligaments in this. First one is the hepatogastric ligament, which is liver to the lesser curvature of the stomach, or another which is falciform ligament, liver to the abdominal wall. Now this nomenclature of the ligament reflects the organ that it connects. Okay, like falciform ligament, ligamentum falciforme, connects the liver to the abdominal wall. Next is coronary ligament. It connects liver to diaphragm. Next is right triangular ligament. Triangular ligament of the liver. Next is hepatogastric ligament. As I said, connects the liver to lesser curvature of the stomach. Next is hepatoduodenal ligament, which connects liver to the duodenum. Hepatocolic ligament, liver to large intestine. Hepatorenal ligament, liver to the kidney. Lineal ligament, stomach to the spleen. Gastrophrenic ligament, stomach to the diaphragm. Okay. Next is gastrocolic ligament, stomach to transverse colon. Gastropancreatic, phrenicoesophageal, phrenicocolic, phrenicorenal, phrenicolineal, pancreato-lineal, lineo-renal, pylopancreatic, duodenal ligament. All these ligaments are connected with in between organs. Next is recess. Recess, they are pouches that are formed by peritoneal folds. Important is because it is important because for places of retroperitoneal herniation. First is duodenojejunal recess. See this, between the duodenum and jejunum. Jejunum is retracted, so we can see duodenojejunal recess. Next is superior ileocecal recess. See, ileocecal recess. Between the ileum and cecum, there is a recess in the superior part. Next is inferior ileocecal recess in the inferior part. Retrocecal, behind the cecum, and intersigmoid recess. Fine. There are also folds which are reflection of the peritoneum that rises from the abdominal wall by underlying structures. Now these are gastropancreatic fold, ileocecal fold. See, these are ileocecal fold here. Next is superior duodenal fold. Okay, superior and inferior duodenal fold. It is formed near the duodenum. Next is median and lateral umbilical fold. See, this is lateral, this is medial, and this is median. Next are sinuses. There is right and left mesenteric sinus. Right is closed sinus and left mesenteric sinus communicates with the lesser pelvis. Closed sinus borders medial is root of mesentery, lateral is ascending colon, and superiorly is transverse colon. Borders medial is descending colon, laterally is root of mesentery, and inferior is sigmoid colon. There are also paracolic canals. This paracolic gutters, lateral abdominal canals are right and left. Right communicates with right hepatic bursa and left into lesser pelvis. See, right paracolic and left paracolic. What are the borders? Medially of the right there is ascending colon and medially of the left there is descending colon. Laterally parietal peritoneum is there. Inferior to the right there is cecum and superior to the left is phrenic colic ligament. Okay. Next is bursa of the abdominal cavity. There is hepatic bursa. Borders are superior there is diaphragm, inferior there is transverse mesocolon, anterior there is anterior abdominal wall, medially there is falciform ligament. Abscess from this medial abdominal cavity may spread here and cause subphrenic abscess through the right paracolic canal. Next is pregastric bursa. Border is left lobe of liver and anterior abdominal wall in the anterior side, and posteriorly there is lesser omentum. Pathologically, abscess from this bursa may spread to omental bursa. Okay. Next is omental bursa, also known as lesser sac of the peritoneum. These are divided into superior recess and inferior recess. The borders superiorly quadrate lobe of the liver, inferiorly transverse mesocolon, anteriorly stomach and lesser omentum, posteriorly parietal peritoneum. Now pathologically inflammation spread to general peritoneal cavity through the epiploic or Winslows foramen. For example, perforation of the gastric ulcer causes generalized peritonitis. Okay. See, this is epiploic foramen of the Winslow's boundary. Okay. Inferior boundary, there is first part of duodenum. Superior boundary, there is quadrate lobe, and here it is seen. See. Anteriorly hepatoduodenal ligament and posteriorly inferior vena cava and hepatorenal ligament is seen. Next is topography of the stomach. Morphologically, the stomach are divided into several parts which are fundus, body, pyrolic or antrum, pylorus, pyloric canal, pylorus, and then it moves to the duodenum. Cardiac region, okay, cardiac incision, okay, fundus, body which has a greater curvature, then pyloric antrum, then pyloric canal, then pylorus. This is lesser curvature. Okay, there are two notches here. As I said, cardiac notch and angular. Okay. Next are layers. Serous layer, muscular, which is divided into external layer, consists longitudinal fibers, middle layer circular, internal layer oblique, submucosa and mucosa. Function of this is reservoir of food, processing ingestion of food into chyme, production of mucus by mucous neck cells and surface lining cells, production of HCl and gastric intrinsic factor by parietal cells, production of pepsinogen, renin and gastric lipase by chief cell, production of hormones such as gastrin and glycine by diffuse neuroendocrine system cells. Holotopy is left hypochondric and proper epigastric region. Skeletopy is cardiac part is in 10th to 11th thoracic vertebrae. Fundus is in 11th thoracic vertebrae. Greater curvature is above the costal arc. Pyloric part is in the 12th thoracic to 1st lumbar vertebrae. Now what is the syntopy of this? Anteriorly, it is pregastric bursa. Posteriorly, left kidney, adrenal gland and pancreas is there. Superiorly, liver is present. Esophagus and diaphragm is present. Inferiorly, there is transverse colon. Medial, liver, duodenum, gallbladder, aorta, inferior vena cava and portal triad is present. And laterally, there is spleen. Arterial supply. Now there is left gastric artery, which is a branch of celiac trunk. Next is right gastric artery, which is a branch of common hepatic artery or right proper hepatic artery. Next is right gastroepiploic artery, which is a branch of gastroduodenal artery. Left gastroepiploic artery, which is a branch of splenic artery. And short gastric artery, which is a branch of splenic artery too. Venous drainage is right and left gastric vein, right and left gastroepiploic vein, which drains into the portal vein. Now veins from the cardiac part of the stomach drains into the esophageal vein. Esophageal plexus, Now we would see the lymphatic drainage. In the lymphatic drainage, there are paraorganic lymph nodes along the gastric and gastroepiploic artery. Now nodes along the splenic artery and common hepatic artery are present. Drainage to the other organs such as spleen and liver in the hilus of these organs are celiac lymph nodes are also present. Okay, now the nerve supply. There is sympathetic trunk, which is T6 to T9. Vagus nerve is present. Afferent phrenic nerve, hepatic and celiac plexus, thoracic and lumbar spinal nerve, vagus nerve, anterior trunk, greater and lesser splanchnic nerve. Ligaments to the stomach, superficial and deep. Superficial, there is hepatoduodenal, hepatogastric, phrenicogastric, gastrolineal or gastrocolic. Deep are gastropancreatic, pyloropancreatic. Topography of duodenum. In the topography of duodenum, there are 4 parts. First is superior part, descending part, horizontal part and ascending part. Okay. Layers are serous, muscular, which is external, internal. External is longitudinal fibers, internal circular. There is orobax myenteric plexus located between these 2 layers. Submucosa has Meissner submucosal plexus and last is mucous layer. What are the functions? Initial digestion of chyme, receives and also receive pancreatic juice and bile. Holotopy is projection on the proper epigastric and umbilical region. Skeletotopy is 1st to 3rd lumbar vertebrae. Syntopy is superficially there is liver and gallbladder, inferiorly jejunum, posteriorly inferior vena cava, laterally pancreas. Arterial supply. There is supraduodenal artery. Okay. Anterior and posterior branch. Anterior and posterior branch of superior pancreatoduodenal artery and inferior pancreatoduodenal artery. See, this is superior pancreatoduodenal artery. Okay. It gives anterior and posterior branch. This is inferior pancreatoduodenal artery. It also gives anterior and posterior branch. Venous drainage is splenic and superior mesenteric vein, which drains into portal vein. Lymphatic drainage is superior and inferior pancreatoduodenal lymph node, which drains into hepatic nodes and further it drains into celiac and superior mesenteric lymph nodes. Now next we move on to the operations on the stomach, which is classified into palliative and radical. Palliative, it is gastrostomy, gastroenterostomy. Radical, it is gastrotomy, vagotomy, resection of the stomach, reconstructive operation, gastrectomy and surgical closure of perforative opening or wound. First we move on to the gastrotomy, which is radical operation. It is done for the removal of foreign substances, tumor, papilloma and bleeding. Inspection of the stomach for diagnosis purpose. What is the procedure? Surgical approach is superior midline laparotomy, then superior midline laparotomy or transrectal of rectus abdominis muscle. Stomach is incised longitudinally and sutured transversely. Fine. Stomach is incised longitudinally and sutured transversely. Next is gastrostomy, which is palliative. It is inoperable. It is done in inoperable cancers of esophagus and cardiac part of the stomach, trauma, burns, and narrowing of the esophagus, craniocerebral trauma or coma. Types is temporary, permanent. Now temporary are minimal gastrostomy, Witzel's gastrostomy, Stamsen's-Cador's gastrostomy. Permanent are Topography's Beck chains. Anesthesia is given endotracheal narcosis. Now we move on to Witzel's gastrostomy. Patient lies on the back. Approach is transrectal left side laparotomy. We make 10 cm incision from the subcostal arc, middle of the lesser and greater curvature of the stomach. Rubber tube is inserted. At the end of the operation, the tube should be in pyloric part of the stomach. 6 to 8 cerebromuscular silk sutures are stitched over the tube. Pyloric part is sutured by purse string. But nowadays, it is replaced by Dacty's modification by putting tube into fundal part. Tube fixed to the skin of the abdomen. Gastric wall is fixed to the parietal peritoneum with 4 to 5 knot sutures, 1 to 1.5 cm from the peritoneal incision, which is called as gastropexy. Wound of the abdominal wall is sutured. Next is Stamsen's-Cador's gastrostomy. Patient lies on the back. Surgical approach is paramedian incision. Tube is not fixed to the anterior wall of the stomach. Then 3 purse string sutures are made surrounding the incision on the fundal part of the stomach for fixation of the tube with invagination of wall of the stomach. Next is Toprov's gastrostomy. Beginning of this method is same as Stamsen's-Cador's operation. No invagination of the wall of the stomach is performed. A gastrostomic canal external to the cavity of the stomach is made. Next is resection of the stomach. There is 2 indications, absolute and relative. Absolute indications are complication of the peptic ulcer such as hemorrhage, perforation, malignation and pyloric stenosis or cancer of stomach. Relative indications is penetration of the ulcer, effectiveness of conservative treatment, recurrent ulcerous hemorrhages, benign tumor of the stomach such as polyp and adenoma. Classifications are according to the size of removal part. Minimal, it is 1/3 of the stomach is removed. Subtotal, 2/3 of the stomach. Vast, 4/5, and gastrectomy, whole stomach is removed. According to the region, it is pyloric, antral, cardiac, and fundal. According to the form, it is circular and segmental. Anesthesia is given endotracheal narcosis. Partial resection on the stomach, there are 2 methods. Billroth 1, Billroth 2. In Billroth 1, stump of the stomach anastomosis with that of duodenum. In Billroth 2, stump of the stomach anastomosis with the initial portion of the ileum. Now, there is third one, modification of Billroth 2. What it is? Polyaurical resection. Stump of the stomach is anastomosis with the initial part of the jejunum. Rox resection, stump of the duodenum is closed. Stump of the stomach is connected to the transrectal end of the duodenum and another end of the duodenum is connected by Y-shaped anastomosis. Next is Balfour's resection. Gastroenterostomy is performed on the long loop of duodenum. Hofmeister's Finister's resection. A distal portion of the stomach is removed with closure of the stump of the duodenum. Stamp of the stomach is anastomosis with short loop of the duodenum done through the opening of the mesenteric colon. Next is gastrectomy. Exophytic cancer of the body of the stomach and infiltrating tumor of the stomach of any locations are indications of this operation. Stomach is mobilized, all vessels and nerves around the gastric region are crossed and ligated. Peritoneum is incised above the esophagus. The esophagus and cruras of diaphragm are exposed near the esophageal opening. The Fyodorov's forceps is applied on the esophagus 5 cm above the tumor. Esophagus is transected between the forceps. The stomach is pushed to the right and removed. Next is combined gastrectomy. Removal of the stomach with the partial or total removal of the adjacent organ in the extension of metastatic growth into this organ. Combined removal of stomach and transverse colon, stomach and pancreas, or combined resection of stomach and spleen. Next is vagotomy. It is done in duodenal ulcer. Method is certain branches of the vagus nerve are excised to reduce the excess secretion of HCl, so there is less recurrence of an ulcer. Pyloroplasty or gastroenterostomy is carried out at the end of vagotomy. There are 3 kinds of vagotomy: truncal, selective, proximal selective. Truncal is cutting the vagal trunk which passes along the stomach and other abdominal organs. Selective vagotomy is excision of all the gastric branches of the anterior and posterior vagal trunk with the preservation of other branches of the abdominal organ. Proximal selective vagotomy is cutting the short branches which innervate the body and fundus of the stomach where parietal cells are seen. Pyloroplasty. Indication is uncomplicated duodenal ulcer which is performed with vagotomy. Gastric ulcer, perforation of the peptic ulcer. Contraindication, it is in pyloric stenosis. It is a plastic surgery of the pylorus. There are two main kinds of pyloroplasty: Finney's and Hennicky-Micheluzzi. First is Finney's pyloroplasty. It is enlargement of the pyloric canal by inserting an inverted U-shaped anastomosis between stomach and duodenum, following a longitudinal incision. Surgical approach is midline laparotomy. All layers of the anterior wall of the pyloric canal are midway between the greater and lesser curvature, 3 cm proximal to the pylorus up to 2 cm distal to the pylorus on the anterior abdominal wall. If ulcer is near the incision, then encircle it and remove it. 2 pairs of the tissue forceps to the upper and lower edge of the incision is pulled apart to allow the widening of the pyloric canal. Wound is closed by through suture with vertical suture line. Next is Hennicky-Micheluzzi. It is enlargement of the pylorus structure by cutting the pylorus longitudinally and suturing the incision transversely. Kocher's method is used to mobilize the descending part of the duodenum so it will lie on a greater curvature of the stomach. Seromuscular limbered suture to connect the greater curvature and duodenum. Anterior wall of the stomach and duodenum is dissected 5 cm away from the suture line along the inverted horseshoe shaped line. Then if ulcer is near the incision, then encircle it and remove it. Suture is applied to connect the greater curvature to the left edge of the duodenal wall. Continue around the corner to unite right edge of the duodenum to left edge of the stomach. Wound is closed by seromuscular suture. Next is reconstructive operation on the stomach. Plastic operation of the stomach after gastrotomy by using fragments of the small or large intestine as a graft or transplant. Next is topography of the liver. In the topography of liver, morphology, there are several lobes are seen. Not several but 4: right lobe, quadrate lobe, left lobe and caudate lobe. Right, left, caudate, quadrate. Fine. On the right lobe, there are some impressions called as colic impression, duodenal impression, renal impression, suprarenal impression. In the left lobe, there is gastric impression and esophageal impression. Function is metabolism, detoxification of the drugs and toxins, storage of glycogen, iron, vitamin and others, protecting the body by Kupffer cell, immunoglobulins, complement proteins, synthesis of bile, plasma protein, clotting proteins, lipoproteins, degradation of hormone which is aldosterone, maintaining the osmotic pressure by synthesizing of albumin, destruction of the RBC is done. The holotopy, it is in right hypochondric and proper epigastric region. Skeletotopy is 10th to 11th thoracic vertebrae. Superior margin is near the 5th rib. Inferior margin 7th to 8th rib near the xiphoid process. Left lobe is 5th to 7th rib. Its syntopy is anteriorly diaphragm and anterior abdominal wall, posteriorly inferior vena cava, abdominal aorta and esophagus. Superiorly there is diaphragm, inferiorly pylorus, transverse colon, stomach, duodenum, gallbladder, right colic flexure, right kidney and suprarrenal gland. Artery is proper hepatic artery. Venous drainage is central vein, drains into sublobular vein, into hepatic vein and into inferior vena cava. Lymphatic is lymphatic lymph node at the hilus and hepatic lymph nodes along the proper hepatic artery. There are celiac lymph nodes and Christine chyli. Nerve supply sympathetic T7 to T10. Parasympathetic is vagus nerve. Afferent is right and left, anterior phrenic plexus, celiac plexus and common trunk of the vagus nerve. Ligaments of the liver are falciform ligament, then coronary, then triangular, right and left. Hepatogastric ligament, hepatoduodenal ligament, venous ligament are also there. Now next is topography of pancreas. Morphology is several parts like head, body, tail. Head, neck, body, tail is present. Now the pancreatic duct, which is Wirsing's duct, joins the common bile duct. This pancreatic duct or Wirsing's duct, it joins the common bile duct, okay, and opens into Vater's major duodenal papillae. Vater's major duodenal papillae into the duodenum. Now the accessory pancreatic duct, it opens into minor duodenal papillae. Okay. Now function of pancreas is exocrine, endocrine. Exocrine, production of lipase, trypsinogen, chymotrypsinogen, carboxypeptidase and amylase. Endocrine is production of glucagon, insulin, somatostatin and pancreatic polypeptides, providing alkaline environment for duodenum by production of bicarbonates. Holotopy is umbilical and left hypochondric region. Head is at the second lumbar vertebrae, body at the first and tail at 12th. Syntopy is anteriorly transverse colon, lesser sac and stomach is present. Posteriorly common bile duct, portal vein, splenic vein, inferior vena cava, aorta, superior mesenteric artery and left psoas major. Inferiorly there is transverse colon. Arterial supplies superior and inferior pancreatoduodenal artery. Venous is superior mesenteric vein. Lymphatic is pancreatosplenic lymph node, pyloric lymph node. Nerve is sympathetic, which is T5 to T6. Parasympathetic is vagus. Efferent is left renal, superior mesenteric, splenic, hepatic and colic plexus. Now next is topography of spleen. There are two ends, anterior, posterior, three borders, superior, inferior, intermediate. Two surfaces, diaphragmatic and visceral. It participates in reticuloendothelial system, lymphopoiesis, hemiopoiesis during fetal life. It is reservoir destruction of erythrocytes. It is in left hypochondric region from 10th to 12th vertebrae or 9th to 10th rib. Anteromedially fundus of the stomach, posteriorly left kidney, laterally diaphragm, inferiorly left angle of the intestine. Splenic artery, splenic vein into the portal vein, lymphatic drainage intraorganic node, splenic node located in the hilus of the spleen, lymphatic node along the splenic vein and celiac node. Nerve is splenic plexus. Next is gallbladder. Now gallbladder Morphology. Several parts are there, which are fundus, body, Hartmann's pouch, neck, okay, and infundibule, which is also Hartmann's pouch. Now it is a storage of bile and it release in duodenum. Make bile more concentrated. Absorption of water and secretion of mucus is done by appropriate dilation and contraction. It is between right costal arc and margin of rectus abdominis muscle. Scaletotopy is ninth rib. Syntopy is anterior abdominal wall. Anteriorly, posteriorly, left quadrate lobe of the liver. Superiorly, inferior surface of the liver. Inferiorly, duodenum and transverse colon. Artery is cystic artery, right hepatic artery. Branches of superior suprapancreatoduodenal artery. Venous, it is superior part is into hepatic vein. Others are cystic vein to portal vein. Lymphatic, it is cystic node, lower hepatic and upper pancreatosplenic node. Nerve is sympathetic T7 to T10, parasympathetic vagus nerve. Afferent is right and left anterior phrenic plexus, celiac plexus and common trunk of vagus nerve. Common bile duct. Topography of common bile duct. It is formed by cystic duct and common hepatic duct. Okay. See, common bile duct, which is this, it is formed by cystic duct and common hepatic duct. Common hepatic duct is formed by right and left hepatic duct. Right and left hepatic duct form common hepatic duct, and from here there is cystic duct, which both commonly forms common bile duct. Okay. Now, the morphology of the common bile duct has four portions. Okay, which is supraduodenal, which is located superior to the duodenum. Retroduodenal, which is located behind the superior part of the duodenum. Next is pancreatic, which is located between the duodenum and head of the pancreas. And next is intraduodenal, which is located inside the duodenum. Now, topography, it is lodged in hepatoduodenal ligament. Behind it, there is portal vein, okay, and left is common hepatic artery. See, behind this is portal vein, and to the left side is common hepatic artery. Fine. Now, the common bile duct, portal vein and common hepatic artery forms portal triad. What does form the portal triad? Common bile duct, portal vein and common hepatic artery. And Carlus triangle, it is formed by cystic artery, cystic duct and common hepatic duct. Cystic artery, cystic duct and cystic artery, cystic duct and common hepatic duct. This forms Carl's triangle. See here, this is Carl's triangle. And portal triad is formed by common hepatic artery, portal vein and common bile duct. Fine. Now the layers are serous, muscular and mucosa layer. Fine. Now next is temporary and permanent hemostatic method in the liver hemorrhages. Temporary and permanent methods are there. Temporary, finger compression of the liver by elastic clamp. Temporary compression to the hepatoduodenal ligament, which should not be more than 15 minutes, which it is used in necrosis of the liver and venous static with hemorrhages of the organ of the GI tract. Now permanent is mechanically applying hepatic suture, ligature of the vessels on the wound, tamponade of the wound. Physical, it is hot compression, electrocoagulation. Biologically, tamponades with the aid of omentum. Special hemostatic preparation is calcium preparation such as calcium carbonate. It should be calcium chloride, It should not be calcium carbonate. calcium chloride. Okay. Then vesicole, aminocaproic acid, galatinol, and uh, etamsilate. Next is Kuznetsov-Pensky's suture. It is done in specialized mechanical methods to stop the liver hemorrhage. Procedure is suturing hepatic tissue with double ligature. Half of the thread is colored. Ligature is withdrawn on the superior and inferior surface and it is not tightened. One thread is intersected, end of the other is tightened up. This ensures hepatic tissue is pulled together by the stitches. General principle of the operation on the pancreas. There are three methods of surgical approach to the pancreas. Through the gastrocolic ligament, through the mesentery of the transverse colon, and approach to the greater omentum from the transverse colon. Operations for the tumor of the pancreas. One is radical and another is palliative. Radical includes pancreatoduodenal resection. It is used in cancer of head of pancreas, cancer of intraduodenal part of common bile duct, cancer of major duodenal papillae. Palliative operations are done anastomosis between intrahepatic bile duct, anastomosis between gallbladder and duodenum, anastomosis between gallbladder and jejunum, anastomosis between gallbladder and stomach. Stages of pancreatoduodenal resection. Mobilization of the duodenum, head of the pancreas and distal part of the stomach is done. Intersecting the common bile duct and duodenum, removal of the head of the pancreas, part of the stomach and superior part of the duodenum is done. Applying the anastomosis between the common bile duct, stump of the pancreas and jejunum, remaining part of the stomach and jejunum is also done. Operation for acute pancreatitis. Indication is acute destructive pancreatitis with sign of peritonitis. Aim is to cease the self-activation of the pancreatic enzyme and autodigestion. Form canal for outflow of the pancreatic juice to eliminate the inflammation process in the hepatobiliary tract. Patient lies on the back, endotracheal narcosis is administered. Superior midline laparotomy is done. Drainage of the omental bursa and catheterization of the gastroomental artery is done. Drainage of the omental bursa, which is transperitoneal approach, extraperitoneal approach. Transperitoneal approach, gastroceliac ligament is dissected, stomach is moved up and transverse colon downward. At beginning, 0.25% of Novocaine solution are administered to the transverse mesocolon hepatoduodenal ligament. Pancreatic capsule is not cut to prevent the additional trauma of the pancreas and generalized process. 5 to 6 gauze tampons and draining tube put in the omental bursa gastrocolic ligament is sutured and lined on parietal peritoneum. Extraperitoneal approach is incision in the inferior border of the left 12th rib. Soft tissue of the lumbar region is dissected layer by layer. Retroperitoneal fatty tissue is stratified till the inflammatory focus. Drainage tube is inserted here, and the advantage is minimal infection in the abdominal cavity and prevention of the formation of postoperative adhesion. Next is catheterization of the right gastroomental artery, isolated in the greater omentum near the pylorus. In the middle of the artery, a catheter with a diameter of 1 mm is inserted. Artery is tightened. Level of the outflow from the hepatic artery is correct. Position of the catheter is controlled by administering 2 to 3 ml of indigo caramine to the catheter. Distal part of the catheter is brought out through the skin. Different drugs like contracal octreotide can be administered through the catheter. Next is splenectomy. The splenectomy is done in the traumatic injury, wound or rupture, echinococcus infection, hemolytic suprahepatic jaundice, Welhoff's disease, which is idiopathic thrombocytopenia purpura, splenomegaly with portal hypertension, congenital anomaly of the spleen. Patient lies on the back or on the right side with a roller placed under the waist. Endotracheal narcosis is given. Upper oblique laparotomy parallel to the left costal arc or superior midline laparotomy is done. Costal arch is drawn out superiorly. The transverse colon and the stomach is drawn out to the right and inferior. Phrenicocholic ligament is dissected. In the case of bleeding in the abdominal cavity due to rupture of the spleen, hemostatic forceps, gastrolineal ligament is dissected, stitched and ligated. To prevent the bleeding, splenic artery is ligated but not ligate the trunk. Only branch of the spleen are ligated. Vein is also ligated simultaneously. Spleen is removed. Puncture is made on the left hypochondriac for drainage. Next is cholecystectomy. It is done for chronic residual cholecystitis or calcus or calculus, phlegm, gangrene, perforation and cancer of the gallbladder. Patient lies on the back with a roller placed under it. Endotracheal narcosis is given. Upper oblique laparotomy parallel to the right costal arc, or Fyodorov's or Kocher's method. There are two types, neck and fundus. Indication: neck, it is done in the absence of inflammation, and fundus, it is when inflammation of the gallbladder is present. In the neck part, gallbladder is identified and small intestine is taken downward to expose the hepatobiliary tract. Retract the liver by the Dever's retractor. Peritoneum on the neck is incised and junction of the cystic duct with the common bile duct is exposed. Cystic artery is exposed close to the cystic duct, ligated at two sides and divided between the ligature. Now gallbladder is attached to this common bile duct by cystic duct only. At this stage, cholangiography is done by passing the catheter into the common bile duct via cystic duct or direct puncture technique. Take two films after injecting 2 to 4 ml of contrast. This excludes stone and shows good outflow into the duodenum, and cystic duct will be ligated. Gallbladder is removed by divide its peritoneal attachment of the liver. In the fundus cholecystectomy, procedure is same as previous one, but the difference is cystic artery and duct ligates after the removal of gallbladder from the liver. Cholecystotomy. Acute cholecystitis, patient with severe cardiovascular disease and respiratory disease, obstructive subhepatic jaundice. Patient lies down on the back with roller placed at the level of 12th rib. Endotracheal narcosis is given. Upper oblique laparotomy is done. Through the operative wound, 1 cm diameter serous purse string like silk suture is applied on the fundus. Puncture is made on the gallbladder with thick needle. Discharge is removed. Gallbladder is opened with scalpel. Calculi is removed. A drainage tube is inserted through this opening and fixed to gallbladder. Purse string sutures are put on the wound. Serous layer of the gallbladder is done. Interrupted sutures to the peritoneum lateral to the aponeurosis. Forbidden to fix it to the skin because fistula may be formed. Next is choledochostomy. Indication is choledocholitis, inflammation of the common bile duct. Choledocholithiasis, biliary calculus, performed before and after cholecystectomy. External drainage, internal drainage. Tube is brought out of the external environment. Internal drainage tube is brought to the duodenum. Surgical approach is carried out as that of gallbladder or superior median laparotomy. Dissection of the hepatoduodenal ligament and long dissection of the common bile duct. Tube is inserted into direction of the hepatic bile duct. Distal end of the tube is drawn out below the incision of the anterior abdominal wall. Topography of jejunum and ileum. Okay. Morphology. There are 4 layers: serous, muscular, submucous, mucosa. Muscular, there is external, internal, longitudinal, internal is circular. Function is digestion and absorption of nutrients. Holotopy is projection on the umbilical region. Scalotopy is second lumbar vertebrae, terminal line of the pelvis. And root of mesentery, left side of the second lumbar, right sacroiliac joint. Anteriorly there is greater omentum. Posteriorly there is aorta, ureter and duodenum. Superiorly there is transverse colon. Inferiorly there is pelvic organ. Laterally there is descending and ascending colon. Artery is marginal artery, branches of 20 jejunal and ileal artery. Ileal branch of the ileocolic artery. Venous, it is superior mesenteric vein into portal vein. Lymphatic drainage is lymph nodes along the superior mesenteric artery drain into pre-aortic lymph nodes. Nerve supply is sympathetic T5 to L2. Parasympathetic is vagus nerve, subserosal or a back's mesenteric and mesenous submucosal plexus. Afferent is phrenic nerve, greater and lesser splanchnic nerve, thoracic and lumbar spinal nerve, hypogastric plexus, hepatic plexus, superior and inferior mesenteric plexus. Now, what are the difference between jejunum and ileum? The location is occupied upper and left part of the intestine. Ileum is lower and right part of the intestine. Jejunum wall is thick and more vascular. Ileum is thinner and less vascular. See, jejunum is thick wall. Ileum is thin wall. Okay. Lumen is wider and often empty. And for ileum, it is narrow and often loaded. Mesentery is windows present, lesser abundant fat, one or two arterial arcades, longer and fewer vasa recti. See, long vasa recti and few artery cascades are lesser in number. Okay. Fat, less abundant fat is also present. In ileum, there is no windows. Okay. More abundant fat. See, 3 to 6 arterial cascades. See, short and more vasa recti. Circular mucosal fold is large and dense. In ileum, small and spared. Villi is large, thick, leaf-like and more abundant. In ileum, it is short, thin, finger-like and less abundant. Pierce patches are absent in jejunum and present in ileum. See, here Pierce patch is present in ileum, here it is not. Solitary lymphatic follicles are fewer in jejunum and more in ileum. Length is 2/5 of the small intestine with the exception of the duodenum, 3/5 of the small intestine with the exception of the duodenum. Diameter is more than 4.5 cm and in ileum it is less than 3 cm. Keep remember, color of the jejunum is red but color of the ileum is grey. Cross section is oval shaped. Ileum it is round shaped. Lymphatic nodes is solitary and ileum it is Pierce patches aggregate. Next is topography of the appendix. There are layers: serous layer, muscular, submucosa, mucosa. It participates in the lymphopoiesis with help of white tissue. Projected on the right inguinal region, it is in the 5th lumbar vertebrae. Anteriorly, anterior abdominal wall and greater omentum. Posteriorly, external iliac vessel. Superiorly, terminal part of the ileum, ascending colon, inferior part of the pelvic bone and right oviduct. Laterally, there is cecum and ascending colon. Arterial supply is appendicular artery. Venous drainage is appendicular vein into ileocolic vein into superior mesenteric vein, then into portal vein. Lymph is inguinal lymph node. Nerve is inferior mesenteric plexus. Now there are various positions of the appendix. There is medially ascending and descending, laterally ascending and descending. There is mesocecal at the level of the cecum, antececal in front of the cecum, retrocecal behind the cecum and subhepatic below the liver. Next is topography of the ileocecal angle. It is located in the inferior floor of the peritoneal cavity and projected on the right inguinal region of the abdominal wall. It is formed between the terminal part of the ileum and cecum. Mesentery of the ileum, superior and inferior ileocecal recesses are located between them. Posterior to the cecum is retrocecal recess. Next is topography of the large intestine. Now morphology. Large intestine is divided into cecum, appendix, ascending colon, right colic flexure, transverse colon, left colic flexure, descending colon, sigmoid colon and rectum. Now junctions are ileocecal angle. Okay, there is ileocecal angle, then there is right colic flexure which is hepatic flexure, left colic which is splenic flexure. Okay, rectosigmoid junction, whereas rectum and sigmoid is forming there is a rectosigmoid junction. See, rectosigmoid junction. Then there is sacral flexure of the rectum. Okay. And perineal flexure of the rectum. Layers. There is serous layer, muscular layer, muscularis. It is external and internal, external longitudinal, internal circular. Okay, submucosa and mucosa. There are three main characters, which is tinea, cole, which consist free tinea. Okay, tinea, cole, which has tinea libra, omental tinea. See, this tinea colea consists of free tinea, which is called as tinea libra, omental tinea, which is called tinea omentalis, and mesocolic tinea, which is also called as tinea mesocoli. Next is Hostra coli, which is also present here. Okay, Hostra or omental epiploic appendage. See, appendages. These are Hostra and these are epiploic appendages. Function is absorption of water, electrolytes and gases, compaction and elimination of the feces, production of vitamin B and K by microflora, conversion of bilirubin into stercobilin. Cecum is projected to the right inguinal region. Ascending colon is projected on the lateral abdominal region. Okay. Right hepatic flexure of the colon is in the right hypochondric region. Transverse colon is projected on the umbilical region. Next is a descending colon is on the right lateral abdominal region. Sigmoid colon is projected to the left inguinal region. Rectum to the suprapubic region. Next is serous covering. The cecum, it is intra or mesoperitoneal. Ascending colon is also mesoperitoneal. Transverse colon is intraperitoneal. Descending colon is mesoperitoneal. Sigmoid colon is intraperitoneal and it has its own mesentery called sigmoid mesocolon. Rectum is supraampullary, which is intraperitoneal. Ampullary is which is mesoperitoneal, and anus, which is extraperitoneum. Now, here cecum might be intra or meso. Transverse colon, sigmoid colon, and superior ampullary region of the rectum. These are intraperitoneal. Ascending colon, descending colon, and ampullary part of the rectum, it is mesoperitoneal, and anus is extraperitoneal. Skeletotopy is 12th thoracic vertebrae or sacrum to the sacrum, transverse colon to the 12th thoracic vertebrae. Superiorly there is stomach, pancreas, liver, gallbladder, duodenum and spleen. Inferiorly there is urinary bladder, uterus in female and prostate gland in male. Medially there is small intestine, laterally left and right paracolic canals, lateral abdominal wall. Anteriorly there is anterior abdominal wall, posterior abdominal wall, great vessels and kidney. Arterial supply to the cecum. It is supplied by anterior and posterior cecal artery. For appendix, there is appendicular artery. For ascending colon, there is right colic artery, supplied by right colic artery. Transverse colon by middle colic artery. Descending colon, it is supplied by left colic artery. Sigmoid colon is supplied by sigmoid artery or rectosigmoid artery. Rectum is supplied by superior rectal hemorrhoidal artery, middle rectal or inferior rectal hemorrhoidal artery. Now, middle colic and left colic arteries form the arc of Riolan. Middle colic artery and left colic artery forms arc of Riolan. Venous drainage is cecum into anterior and posterior cecal vein into superior mesenteric vein, Ascending colon through right colic vein into superior mesenteric vein. Proximal half of the transverse colon drains into middle colic vein to superior mesenteric vein. Now distal half of the transverse colon drains into middle colic vein, but it drains into inferior mesenteric vein. Descending colon through left colic vein to the inferior mesenteric vein. Sigmoid colon through sigmoid vein into inferior mesenteric vein. Rectum, supraampullary, suprarectal vein, portal vein. Ampullar, middle rectal vein into inferior vena cava. Anal canal, inferior rectal vein to inferior vena cava. Portocaval anastomosis is done in portal vein and inferior vena cava. Lymphatic drainage is intraorganic lymph node, epicolic, pericecal, para-aortic and colic. Nerve supply is sympathetic T5 to L2, parasympathetic vagus nerve, afferent phrenic nerve, greater and lesser splanchnic nerve, thoracic and lumbar spinal nerve, hypogastric and hepatic plexus and superior and inferior mesenteric plexus. Now difference between the small and large intestine is appendice and epiploica is absent in the small intestine, present in the large intestine. Tinea coli, Hostra coli is absent in small intestine and present in the large intestine. Distensibility is less in small intestine, more in the large intestine. Fixation is greater part is freely mobile, greater part is fixed. Villi is present in the small intestine, absent in the large intestine. Transverse mucosal folds are permanent in small intestine and obliterate when longitudinal muscle coat relaxes. Pierce patches are present in the ileum and absent in the large intestine. Length of the small intestine is 6.5 to 7 meter. Large intestine it is 1 to 1.5 meter. Diameter is small of a small intestine and large for large intestine. Thickness of the wall is thicker of the small intestine and thin of the large intestine. Color of small intestine is rosy and large intestine is blue plus grey. Now we move on to the intestinal sutures. There are general requirements for putting the intestinal sutures are we need to observe the sepsis, accurate hemostasis and minimal damage of the tissue, especially those of mucous membrane and submucous layer. Impermeability by the means of securing wide contact of the serous surface and adaptation of rest layers of the wall. Absorbable material sutures are applied like catgut sutures, and non-absorbable material while putting seromuscular sutures. In connection with the intestinal peristalsis, sutures from the absorbed material should be put as continuous from non-absorbable material, interrupted one. Intestinal suture is placed with the aid of the round needle or like straight or circle. Now there are types of sutures. Dirty sutures, these sutures reach the intestinal lumen. Clean sutures reaches only serous and muscular layer. Through suture, it is continuous catgut thread is laid through the borders of the suture wall by the principle of mucous membrane, serous membrane and serous membrane. Serous membrane, mucous membrane, so on. Internal to external, external to internal. Next is Schmiden's suture. Thread goes from external to internal, internal to external, like mucous membrane, serous membrane, and serous membrane to the mucous membrane. Thread is tightened after each stitch. Interrupted suture is through all the layers of the wall inside the lumen. Next is aseptic suture. Seromuscular suture. Pricking in and out of the needle in every stitch is performed through the serous and muscular stitch. Purse string suture is seromuscular suture is performed by the stitches with a circle used to bury the stump of the appendix, duodenum, duodenum or ileum, as well as for suturing the small stab wound of the stomach and intestine. After suturing, the end of the needle are tightened and tied up and the stump or wound is buried inside the wall of the organ. Z-shaped suture, it is an additional suture to the purse string suture and is placed above. Next is hemostatic suture. It is done creating hemostasis of the vessels of the cross wall of the alimentary tract. Edges are sutured by catgut suture and Schmiden's suture. Special hemostatic sutures like Riverden's, Multinskovsky buttonhole suture. After putting the edge of the suture, the needle is passed into the loop and laced. Stitch suture, most frequently used in suturing the stump of the stomach during resection. Next is mechanical suture, widely used in the operations on GI tract. Suture performed with the help of suturing apparatus and tantal containing staplers. More often, Eucasia 60 apparatus for GI anastomosis and CAS apparatus for round suture on large intestine. Intestinal anastomosis. First is end-to-end anastomosis. The direct connection, like end of the organs with the double or triple layer suture. Disadvantages is possible constriction of the intestinal lumen. It is not recommended to apply intestinal end with different diameters like Zolli suture, Skimmend sutures. Zolli suture is anastomosis of the posterior wall of the intestine. It is continuation and dirty suture. Skimmend suture, shoe-like suture, penetrates all time from internal to external surface of the intestine. Side-to-side anastomosis. Stumps located isoperistaltically, suturing both sides of the intestine or stomach with the intestine. Advantage and disadvantages. Absorption of the constriction at the site of anastomosis and allowable anastomosis between the intestinal end with different diameter. Disadvantages. Development of the necrosis at the site of anastomosis due to poor blood supply in the area. Next is end-to-side anastomosis. Connect the section of the GIT with different diameters. Resection of the stomach. Stump of the stomach is sutured to the side of the small intestine. Palliative method is revealed condition of the patient suffering from cancer. Next is side-to-end anastomosis. Rare method. Connect proximal side of an organ with the distal end of the another organ, which is Roux gastroenterostomy and iliotransverse enterostomy. Now next would be side-to-end. This is done. Operation on the small intestine. There are two, palliative and radical. Palliative is divided into different kind of stomas according to the location, divided into jejunostomy, ileostomy. According to the structure, it is tubular, which is temporary, lip shape, which is permanent. Jejunostomy is creating an opening between the jejunum and surface of the abdominal wall, used in feeding of the patient, performed any pathology of esophagus or stomach. Ileostomy is creation of an opening between ileum and surface of the abdominal wall, done to remove the intestinal content. Now next is radical. Includes duodenotomy, jejunostomy, ileostomy and resection of the small intestine. Resection of the small intestine. It is done in tumor of the small intestine or mesentery. Necrosis of the small intestine in acute ileus or strangulated hernia, thrombosis of artery of small intestine. Procedure is patient lies on back, endotracheal narcosis is given, midline laparotomy is done. Separation of mesentery from the intestine is done in two ways. Parallel separation, lateral approach. Parallel separation of the intestine at the level of the artery or wedge shaped. Separation with the preliminary ligature of the vessels near the root of mesentery. Lateral approach is applied in the extensive resection and tumor of intestine. Stiff hemostatic clamp. Proximal and distal end of the removal part of intestine in oblique direction, done to provide good blood supply for free margin of intestine at the region of anastomosis. Soft intestinal clamp 1 to 1.5 cm superior and external to the place of resection. Removed part is dissected in the oblique direction parallel to the stiff clamp. After the removal, the intestinal end are drawn together by anastomosis. In the operation of duodenum, it is include resection and puncture of the duodenum. First is resection by Kocher's method and Nakayama's method. Kocher's method is mobilization of duodenum, anastomosis between esophagus and duodenum, and is performed in gastrectomy. Nakayama's method, diaphragm and pancreas is sutured together and anastomosis is carried out between esophagus and duodenum. Second is puncture. Purse string is done in intestinal wall, then a puncture is done, opening is closed by pulling a suture. Next is Witzel's geogenostomy. Indication is metastatic spreading of the cancer of the stomach, chemical burn of the stomach, inapplicable performance of gastrostomy. Procedure is patient lie on the back, endotracheal narcosis is administered, surgical approach is superior midline laparotomy. or superior left side transrectal incision. Loops of the jejunum 40 to 50 centimeter in length from duodenojejunal flexure is identified and drawn out. An intestinal anastomosis is performed between adducting and abducting ends. A geogenostomy tube is inserted in the abducting loop of geogenum and later buried by interrupted silk suture. Opening of intestine above the tube, stitched with purse string and interrupted suture. Tube is fixed to intestinal wall with catgut suture to prevent the formation of sliding hernia. Tube is thus located in the canal, forming the intestinal wall with serous covering. Incision is made to draw out the tube through anterior abdominal wall. The intestine around the tube and formed canal is fixed to internal surface of the abdominal wall seriomuscular suture. The operative wound around the stoma is stitched and tube is fixed to edge of the skin wound. Ileostomy. It is done in paralytic ileus or inoperable tumor. Abdominal cavity is approached. Oblique incision is made 6 cm in length near the inguinal region, which is 4 cm above the inguinal ligament. Loop of the ileum is stitched to dissected edge of the parietal peritoneum with the continuous suture. Intestinal wall is cut longitudinally. Dissected edge of the intestine is stitched to the edge of the skin with interrupted suture. Lip-shaped stoma is formed and operation is required to remove this stoma. Operation on the large intestine. Palliative and radical. Palliative include different kinds of stoma. According to the location, cecostomy, transverse colostomy, sigmoidostomy. According to the structure, it is tubular, which is temporary, lip shape, which is permanent. Left side hemicolostomy is removal of the sigmoid colon, descending colon, left colic flexure and left half of the transverse colon. Operative stage is same as right side radical. End-to-end anastomosis is between the transverse colon and stump of sigmoid. Oh, sorry. Palliative is till here. Radical, there is first stage resection, transverse colon and sigmoid colon. There is right side and left side hemicolotomies. Now right side is removal of cecum with terminal part of ileum, ascending colon, right colic flexure and right half transverse colon. An operative stage is mobilization of right half of the large intestine with terminal part of ileum, ligature of the main arterial trunk, removal of right half of the left large intestine with appendix, section of ileum which is 10 cm in length, end to side to side anastomosis is done between the stump of large intestine and transverse colon. Now this left side is written here as I said previously explained. Resection of large intestine. Indication: cancer, volvulus and interception of the colon accompanied with its necrosis. Fistula of the colon, ulcerative colitis. Procedure is patient lies on the back, endotracheal narcosis administered. The surgical approaches may be pararectal, midline, transrectal or combined. One stage primary resection of the sigmoid colon. Abdominal cavity is opened by inferior midline laparotomy. Vessels are ligated at the root of the mesentery. Mesentery is dissected like a wedge shaped from its root till place of resection. It is done to prevent marginal artery at the proximal part. Stiff intestinal clamp at the end of the removal section and soft intestinal clamp at remaining part of the colon. Colon is intersected and removed with the part of mesentery. End-to-end anastomosis is done. Triple layer suture is applied. First layer is continuous catgut suture, posterior edge of the anastomosis. Then screwing sutures to the anterior edge. Second layer is interrupted silk suture, which is seromuscular suture. Third layer interrupted silk seromuscular suture. Interrupted seromuscular suture. An opening of mesentery is done by interrupted suture. Cecostomy. Indication is acute ileus, temporal fecal fistula in case of operations on the large intestine, ulcerative colitis, wound on the large intestine. Patient lies on the back, endotracheal narcosis. Surgical approach is oblique laparotomy, right iliolinguinal region. Cecum is drawn out through the surgical wound. Seromuscular purse string are sutured with a diameter of 1 cm is applied. Its wall is cut at the center of the suture along the tinea coli. Rubber tube is inserted into its lumen. End of the tube is laid down along the tinea coli, buried by interrupted seromuscular suture. Edge is Edge of the parietal peritoneum is stitched with serous covering of the cecum around the absorbed tube. Abdominal wall is sutured around the cecostoma, fixation of cecum. In case of removal of fistula, rubber tube is removed and fistula close on its own. Next is transverse colostomy. Indication is tumor or diverticulum of distal half of the colon. Incision is longitudinally done on the rectus abdominis muscle, proximal half of the transverse colon. Then incision on the proximal half of the transverse colon, right of the middle colic artery. Greater omentum is separated from the bowel for 4 to 6 inches and returned to the abdomen. At the level of the colostomy is placed, rubber tube is inserted through the avascular area of mesocolon. Tube is drawn out from the previous incision. Sutures are placed around the skin bone. Next is appendectomy. Indication is acute or chronic inflammation of the appendix, tumor of the appendix. Kinds of operations are open, closed. Open is laparotomy, anterograde, retrograde. Closed is laparoscopy. Laparotomy, patient lies on the back, endotracheal narcosis or local anesthesia is given. 3 kinds of surgical approaches are there. Lower oblique laparotomy, which is Volkovich-Diakonov's axis. Pararectal laparotomy, which is Lenard's axis. Inferior midline laparotomy. Now, lower oblique laparotomy is applied in the acute appendicitis with a pain in the right iliac fossa. Pararectal laparotomy is used when diagnosis is not confirmed before the operation. An inferior midline laparotomy is applied in the presence of sign of peritonitis. Point of incision is McBurney's lateral 1/3 of the right spino-umbilical line. Lance point, midline of a bispinal line on right. Anterograde appendectomy, retrograde appendectomy. Anterograde is done in absence of inflammation. Retrograde appendectomy is done in the presence of inflammation. Appendix is identified by finding the free tani. Appendicular artery found, clamped and ligated. Base of appendix, there is Ogneve's window, divide of vessels and ligature of mesenterium. With the help of Koch's forceps, base of appendix is pressed, ligated and cut is removed. Stump of appendix is ligated, purse string sutures are put. This stump is pulled down by making an invagination. At the end, there is Z-shaped suture is made. Retrograde appendectomy is done in the inflammation of appendix, same as anterograde. Only one difference is appendicular artery is ligated after removal of the appendix. Last is Medley's formation of the artificial anus. It is done in wound of the rectum, inoperable tumor of the rectum, cicatricial narrowing of the rectum. The procedure is patient lies on the back, local infiltrative anesthesia is given, abdominal wall is oblique incision, left inguinal, ilioinguinal region, edge of the skin is connected with edge of the pararectal peritoneum with continuous catgut suture. Through the wound, loops of the sigmoid colon with the mesocolon are drawn out. Mesenteric margin, abducting and adducting ends are connected to each other with interrupted silk suture. Both the ends lie parallel to each other, forming bishaft. Walls are separated by a septum called spurt. Artificial anus is unishaft and done in case of removal of the whole peripheral part of affected intestine. Abdominal wall is sutured, remaining only central end of the intestine. Here we finish the complete topography and operation of the abdominal wall and abdominal cavity. Thank you. Keep watching, keep learning. Bye bye.